morning. Thank you for coming to this presentation. I'm very happy to have this panel also. They are my colleagues and friends who I have been working for a long time. And thanks to Shamna for setting the stage, so I will be able to pass some of the slides quickly because she did a great job. Although this is not working. Okay. So I will talk to you about an AHRQ-funded project that we are doing here. It's a multi-site project with Hopkins, Wisconsin, and Florida, with Hopkins being the lead of this project, a 5-year project. And some of the collaborators of mine are in this room, Dr. Fackler, Ash, Nicolette, and Scott, and if I am missing anyone, I apologize. So the goal of this 5-year endeavor is to describe cognitive teamwork involved in care transitions in pediatric trauma patients, and to develop and test design requirements for future health IT that supports this cognitive teamwork. Shauna talked about complexity, one big, and I will give the most extreme complexity example probably here. We work in team-based or multi-team systems to provide care to patients. But current health IT solutions do not support that teamwork adequately. And I will show you some examples of that and also give you some ideas about the way we are going towards this, developing some design requirements for these multi-team systems. So today I will talk about information needs of 2 types of handoffs care transitions, pre-hospital, some examples, pre-hospital EMS to ED Trauma Bay transfer, and ED Trauma Bay to PICU transfer. There is a lot of qualitative work at that component, and we have also done quantitative modeling of the major patient pathways in these care transitions using trauma registry data. And now, finally, after like 8 months of struggle, we have access to EHR data that we will do some more quantitative data. So we will be able to use both qualitative and quantitative modeling to understand the work, the tasks that Shauna was talking about to some extent, so that we can develop some design requirements, prototypes and design requirements based on that. This is the Pediatric Trauma Bay. Actually, it is downstairs if you walk there, and these are some of the roles you see, the cards. There are so many people sometimes. The sicker the patient, the more people there are there, and some of them are not doing much, but they are there. It is interesting. And when you go, and when patient comes, there is a nurse there whose job is in the ED just typing what is going on, okay? And this is the EPIC ED trauma narrator. She's, or he is typing everything. You can see the scroll there with the red arrow. And in like 20 minutes or so, this patient will probably be transferred to PICU with a different set of clinicians. So how can anybody, even the most high expert clinician, can make sense of this data presented to them under time pressure environment and just look at this and make sense of what is going on with this patient? Is that possible? Is that possible, Dr. Perry?
I usually ask someone again.
Again, that is the solution. You always see people talking to each other, and you also, there are like 10,000 people there. You don't know half of them. You go and find someone who you know, trust, and start asking. And why is that I'm highlighting that? Verbal communication is great, but it is not always the most efficient way according to the coordination theory. And in healthcare, we have no choice, so we always use that approach. And I use also, actually I use SEIPS 2.0, but I didn't know Shauna was going to get into that detail. I am using this model to guide the entire R01 study. I will not talk about it because of time. We are using this thing called contextual design approach, which is a particular human-centered design approach. And for the different two parts of the study, aim 1 and aim 2 that I mentioned at the beginning, aim 1 is more like figuring out how the work is done. Aim 2 is coming back based on what we have learned iteratively, developing design requirements and prototyping. So it's an iterative process, and it goes back and forth. It is far from being linear, especially in this complex team-based work. We use multiple qualitative and quantitative data collection and analysis methods. One big method is like task analysis or process mapping that Shauna mentioned, how work is being done versus actually or is taught to be done, information flow diagrams, etc. And then we are developing preliminary design requirements based on those, and hopefully close to the end of the project we will do more and more of the prototyping. I can talk more about that, but one key aspect is we have researchers, HF researchers, informatics researchers. HF also has subspecialties, human factors. We have both cognitive ergonomists and also macroergonomists. I'm more of a macroergonomist. Nicolette is a cognitive ergonomist, for example. We have a lot of clinicians, different types of clinicians. And we also have people like Scott and Matt who are really heavy on data analytics. When we looked at this complex work system, we did this thing called role location matrix. Who at what point actively involved in patient's care. 58 total roles for 7 different locations. These are just the different roles. And you don't even know who are some of these people when you are providing care to this patient. This is and we did very detailed flow charts. This is the overall flow chart of how a patient comes to ED Trauma Bay, and we need to think more and more on this longitudinal path of the patient rather than focusing on how we will improve care in the ED, how we will improve care in the ICU. The ultimate thing is how we will improve care given to the patient. And this is, these are also very, very simplified models of what we have developed on how people coordinate care, different methods to coordinate care across different stages of care. What we did is we did a lot of interviews and expert panels, expert sessions, and also some informal observations to understand the information needs and characteristics of these information or data so that we can develop design requirements. And this is a preliminary version of our analysis of qualitative results. What are the different goals of the certain types of information? What are the attributes of this information, etc. And I will talk about some of these. One big aspect is uncertainty. If kid has an abnormal chest film and had infiltrate, that could be a pulmonary contusion or it could be aspiration. So then the right way to put on that on the problem list is to put it on as a pulmonary infiltrate. And I don't know if it is blood or infection. Until you got a degree of precision, you shouldn't be typing pulmonary contusion in because that's going to force people down, that's going to lock people's mindset. Someone puts some diagnosis there and everybody thinks that is the diagnosis, and there is no way currently in our electronic health record to show any uncertainty associated with that. So one big attribute of these information dynamic work systems are uncertainty of information and how to represent that in the interface. Another big problem is the problem with problem list. Problem list is basically what is wrong with this patient. And we know from basic situational awareness theory that for a team to be performing high, any team, healthcare or non-healthcare, they need to be first aware of what is the problem, what they are trying to solve. In our EHR, that is not the case. Sometimes you see many problems that are so hard and irrelevant, and sometimes you see no problems documented, even if patients stayed here for a few days, because nobody uses this feature or rely on that. And then if you forget to put something on the problem list, this can happen. Suddenly, all of a sudden, their spleen starts bleeding because you forgot that they had splenic injury and nobody put it on the problem list. A lot of reliance on verbal communication, and actually they are doing iPhone to take photos of the CT scan at the referring hospital if patient is being transferred for immediate transmission to trauma care team, so that the neurosurgery at Hopkins can decide whether we will go to the OR. These are like big, these are technologically probably possible solutions that we are, are like waiting there to get done, basically. And I have more examples, but because of time, I will skip some of them. One big area, though, I need to mention briefly. Patient comes, everybody wants to touch the patient. The sicker the patient, the more you touch the patient in the ED Trauma Bay, and then you don't listen. And the EMS, and EMS is gone in a few minutes, and when PICU needs a critical piece of information from EMS, that information is not available. Based on all of this, we are now developing different preliminary design solutions, design considerations, such as being able to see entire story of the patient, linking actions back to the problems that they address, etc. A summary abstract view of patient story so that the, for example, PICU can see what happened until that point in time. And we have much more of these being developed. So this is an ongoing project. So I will just jump to the quantitative modeling that is simultaneously going on. We have used very briefly, we are using the ED trauma registry data for Alpha and Bravo level 1, level 2 trauma patients. And we are modeling how patients actually flow in the trauma bay and what we have seen. So it is not only technology improvement, it is also process improvement given the socio-technical nature of this work. For example, here we have seen an interestingly high number of PICU to discharge patients, many patients being discharged from PICU to directly to home. And we are trying to investigate why this is happening rather than what is more expected in general, PICU flow or discharge. Is PICU resources, are PICU resources utilized unnecessarily? Things like that we are trying to figure out. And next, what we will do, we got our hands on the EHR data, finally, that we will look at the progression of the problem list, actually, and changes in team composition so that we can quantitatively model what is in the EHR, using what is in the EHR, and compare it based on our qualitative analysis. And then, based on all of that, we will continue developing the design requirements. Thank you.